I look forward to talking with you about our CAMEO trial, care management for effective use of opiates. So give some findings from that. I'd like to acknowledge that this was VA funded from HSR&D. Also like to acknowledge being part of a great study team that carried out this trial. So this is our CAMEO study team here. So as we all know, chronic pain is a big problem in the U.S., and this was really highlighted in kind of a Sentinel report from the Institute of Medicine back in 2011, showing that 100 million U.S. adults have chronic pain, which equates to actually 1 in 3. Also from the same report from IOM, that the report is called Relieving Pain in America, that chronic pain is extremely costly as well, and costs between $560 and $635 billion a year in direct and indirect healthcare costs. So concerning about chronic pain, as our U.S. population ages, the number of pain conditions is expected to rise, and this has actually been seen, especially for low back pain and osteoarthritis conditions of the knee and hip especially. We also know that pain is a significant problem among our military veterans. And Kerns and Clark have shown in different epidemiologic studies in the VA that 50% of veterans in primary care report chronic pain. And the prevalence is even higher among our women veterans, that 3 and 4 have chronic pain conditions. So specifically about low back pain and why it's so important, that low back pain is the most common chronic pain condition that we see. It leads to enormous burden and patient suffering, large detriments in health-related quality of life. It's the most common, and this is worldwide, most common cause of disability of pain conditions, and it leads to very exorbitant healthcare costs. So talking a little bit about treatment, what is the optimal treatment for chronic low back pain? We still have many questions in this area. We have many options to treat pain, but we don't have the optimal approach. We know that we have medications that have been used, interventional treatments such as steroid injections have been used, rehabilitation approaches from physical therapy and occupational therapy. We have psychological approaches, different psychotherapies, cognitive behavioral therapy, acceptance commitment therapy. Surgeries have been used for chronic low back pain. And more recently, we're using complementary and integrative health approaches such as acupuncture, chiropractic, and massage. So we do have evidence for these individual approaches to treating low back pain, but most of the studies have been limited by limited time frames. They're shorter trials, 3 months generally, and we don't really know how durable these treatments are. Most of the trials have been kind of framed in the efficacy paradigm rather than more effectiveness or especially comparative effectiveness. We have very few comparative effectiveness trials looking at low back pain treatments. So we do have evidence looking at analgesics. We have evidence that analgesics do help for chronic low back pain treatment. We have a robust evidence that cognitive behavioral therapy is effective for chronic low back pain. But what hadn't been done when we were designing CAMEO is that these treatments hadn't been compared head to head in a comparative effectiveness. And whenever we're treating chronic pain, we have to also, view it in the context of the opioid conundrum, that many of our patients are prescribed opiates. Since the late 1990s to 2013, opiates had dramatically increased in prescriptions. Along with that dramatic increase in prescriptions, there were concerning trends in the risk of in opiate overdoses and admissions for opiate use disorder treatment. So in that context, we designed the CAMEO trial, and this is our overall study objective, and we wanted to compare the effectiveness of pharmacologic treatment and optimization of pharmacologic treatment versus cognitive behavioral therapy for veterans with chronic low back pain that were prescribed chronic opiate therapy. Specifically, we were wanting to compare the two study arms, the pharmacologic arm versus the behavioral CBT, on our primary outcomes of pain impact pain severity and pain interference at 6 and 12 months. We also had a variety of secondary outcomes that we wanted to examine, looking at intervention effects on things like how the patients perceived they improved or didn't improve, health-related quality of life, pain beliefs, psychological factors, and opiate dose. So our choice of study design, our choice of measures and our intervention was really guided by the biopsychosocial approach. And in brief, the biopsychosocial approach is the most common conceptual model used in chronic pain trials, and it posits that there are biological, there's psychological, and there's sociocultural influences to a patient's or a person's individual pain experience. And for the most optimal pain treatment, we must try and address those three kind of domains of biological, social, and psychological. So here's our CAMEO trial design, and we were targeting, again, veterans with chronic low back pain, and they must have met chronic low back pain and a variety of other eligibility criteria, which I'll discuss. They were randomized to one of two arms, the pharmacological arm or the behavioral CBT arm, and then followed longitudinally from baseline to 12 months. In terms of setting, this was conducted at our VA across the campus here in Indy. We have 5 primary care clinics there at the medical center, and then we also have 2 community-based outpatient clinics in Bloomington and Terre Haute that we recruited participants from as well. So in terms of, we recruited 261 participants. They all had moderate to severe chronic low back pain. And that was moderate pain was defined as a brief pain inventory score of 5 or greater. And I'll talk a little bit more about this specific measure. They all had pain for 6 months or longer. And they were prescribed long-term opiate therapy, which we define as 3 months or longer on opiates. Here are other exclusion criteria. So we excluded those with severe medical conditions. Those were patients like had COPD on home oxygen, uncontrolled hypertension, heart failure, class 3 or class 4. They had, active psychosis, schizophrenia, active suicide ideation. If they had a pending back surgery, if they had moderately severe cognitive impairment on baseline, active substance use disorder, which we define as receiving treatment for SUD, if they were planning to become pregnant, or we had some other ongoing pain trials and they couldn't be involved in those to be involved in CAMEO. Overall, this is a summary of our 2 interventions. The pharmacological arm was based on a nurse care management model. I was focused on analgesic treatment and optimization according to an algorithm. And our behavioral CBT was cognitive behavioral therapy that was delivered by a clinical psychologist. More specifics, our pharmacological arm was guided by an algorithm-based treatment. That this algorithm was developed by Kurt Kroenke and Aaron Krebs and myself. Back in the day, we use the opioid guideline of 2000 U.S. or excuse me, a VA DOD guideline that kind of guided our management of opiates at that time. That was somewhat different than opiate management now. All aspects were delivered by a nurse care manager, and then the nurse care manager was supervised by a study MD and a PharmD. This was our analgesic algorithm. So these were non-opiates, and in a stepwise approach, we generally prescribe simple analgesics in step 1, and those were, Tylenol or acetaminophen or naproxen as our first step, and trying to optimize their dosing and duration of use. In step 2, we used a variety of other NSAIDs. Of step 1 were ineffective. So you see the list of NSAIDs that we use there. In step 3 was kind of a potpourri. We used topicals. At that time, we only had topical capsaicin. We did not have topical diclofenac at that time. We used the gabapentin as an anticonvulsant. Pregabalin was limited to our neurologists, so we did not use pregabalin at that time. And we used some muscle relaxants like cyclobenzaprine and methylcarbamol. Tramadol at that time was considered a weak opiate and was not a DEA scheduled medication. So that was actually included in our analgesic algorithm. And in step 4, we used our tricyclic antidepressants, nortriptyline, amitriptyline. In terms of opiates, we had prioritized short-acting opiates over long-acting opiates, and the most common opiates that we use were the combination of hydrocodone and acetaminophen, trade name Vicodin, or oxycodone, acetaminophen, or Percocet. We prioritized those short-acting over the long-acting. The long-acting we had, with the exception of morphine IR, which is a short-acting, but we generally for short-acting, we use morphine sustained release there, and some patients were actually already on methadone. So the treatment was guided through weekly case management meetings where the nurse care managers met with a study MD. The nurse care managers had regular contacts with participants approximately every 2 to 4 weeks during the study. And they would monitor the patient's or the participant's response based on their pain function and their pain severity. They wanted to see, how they were responding. They wanted to see how they were adhering to therapy, assessing them for any side effects. And to be really patient-centered, we also asked patients, did they want a change in treatment as well, and took that into account as we guided their analgesic treatment and optimization. In the behavioral arm, the clinical psychologists had regular contacts with participants as well. Could be either phone contacts or face-to-face, whatever is most convenient for participants. And this treatment period was over 6 months. The treatment really emphasized how to better cope with their pain coping skills, and some pain self-management strategies that we tested in other trials of ours. These were delivered by clinical psychologists and clinical psychology PhD students. This is a sense of what the content of these interactions were, and they involved a lot of skills and self-management strategies, from starting out with just some pain education about the overview and causes of low back pain, to how to handle if you have an exacerbation or a trigger of your low back pain, how to handle those flare-ups, how to increase and recommend increasing physical activity rather than bed rest. That was an old recommendation. How to set goals and plan for the future, how to solve problems, how to overcome a very common concept of fear of movement or fear of re-injury when you have low back pain, instilling more positive thinking, the idea of how to cycle periods of activity with periods of rest, how to schedule more pleasant activities to distract from the experience of chronic low back pain. We taught different relaxation techniques, from deep breathing techniques to progressive muscle relaxation, ideas of how to divert your attention away from your chronic pain, some tips on sleeping better, how to more effectively communicate with your providers, and then sometimes reframing some of these negative thoughts related to chronic pain. So the behavioral arm was supervised by a pain clinical psychologist, and it was guided by a treatment manual, a CBT treatment manual that guided each of these 8 sessions. In terms of our primary outcome, we looked at the brief pain inventory. We looked at the total score, what we termed the pain impact, that combined severity and pain interference, and I'll talk a little bit more about that. We looked at statistically a between group difference of 1 point, meaning clinically significant differences, or a kind of a moderate effects standard deviation effect size difference, and we use mixed effects models for repeated measures. This is our primary outcome, and so it has 2 main constructs, severity and impairment, and it's over the last week. So in severity, you see, describe your pain in the past week at its worst, least, average, and right now. And then impairment or interference is how has your pain interfered with these 7 kind of activities or domains that you see listed here. And for the pain impact score, those were combined. We get a combined score, a 0 to 10 score, with higher scores representing more severe impact or severity or interference. We had a variety of other measures looking at psychological symptoms, depression, anxiety, PTSD, looked at stress, we had a measure of opiate misuse, opiate side effects. We looked at health-related quality of life, a variety of different pain beliefs from catastrophizing to something called centrality of pain. We looked at opiate dose, an actual functional measure, objective functional measure. We looked at self-management behaviors, some other constructs that are really common, poor sleep and fatigue, and we're going to look at healthcare costs and utilization. So in terms of results, so randomization didn't work. It's not really reflected on this slide at all. This is overall characteristics of our sample. Mean age was about 58. Most, very large majority, like most VA studies, are largely men. More than half were married. About 73% were white, 21% black. We also looked at income just on a self-reported, and 72% viewed that they had just enough to meet and make ends meet or adequate income. They had pain for an awful long time. They had pain on average for 22 years. This was a complex group. 3/4 had some form of disability. This was either VA service-connected disability or Social Security disability. We also asked about 14 different medical, psychological conditions, and they rated having 4 of these 14 comorbidities. So that, highly comorbid group. They also very experienced in terms of previous pain treatments. So these pain treatments are based on at baseline. So they'd seen someone in a pain clinic or pain school, which is generally a pain education intervention. They'd seen psychologists. They'd been to physical therapy commonly, or an orthopod or rheumatologist. So they'd had previous pain treatments and were very experienced in that way. At baseline, these are a look at our baseline pain measures. And so again, our BPI total, or our pain impact. And so there was no differences across our study arms of behavioral and our pharmacologic. These scores represent moderately severe. So again, this is a score from 0 to 10 with higher scores representing more severe pain impact, pain severity, and pain interference. So moderately severe at baseline. I just also want to highlight, that this was a highly disabled group in terms of the Roland-Morris disability. Generally, a score of 7 on the Roland is considered moderately severe, and these patients or veterans had a score of 16. So very impaired group. They had at baseline moderately severe depression measured by the PHQ-9. Pain catastrophizing is a pain construct that has to do with how patients might ruminate or magnify their pain complaints. And generally a score of 16 on this scale is viewed as moderately severe. So they were high pain catastrophizers, which is a poor predictor of pain treatment response. So in terms of our primary results on our outcomes, so again, our pain impact. So we looked at the BPI total score, the pain impact, which in the pharmacologic arm, in the behavioral arm decreased by 0.64 across at 12 months. In the pharmacologic arm, it decreased by 1.14 points, with a between group difference of 0.5 points, with a significant p-value of 0.04. That's on pain impact. Similar finding on pain severity here. So the BPI pain severity decreased by 0.4 in the behavioral arm and decreased by 1.02 points in the pharmacologic arm, with a between group difference of 0.62 and a significant p-value there. In terms of pain interference, we saw similar direction of response, but not a statistically significant difference. Mean decrease from baseline in the BPI interference was 0.71 in the behavioral group, and then 1.19 in the pharmacologic group. Between group difference of 0.48, the p-value of 0.08. So those are our primary outcomes. So what about secondary outcomes? We looked at some psychological variables here, and listed here we have PHQ-9 depression, GAD-7 anxiety, PCL-17, PTSD symptoms. Audit C is a measure of alcohol risk symptoms. And you see that across both arms that there were decrements in these symptoms of depression, anxiety, PTSD, audit C, but no differences across the study arms. There was no differences across study arms in things like stress, opioid misuse. We had one measure of opioid misuse. We looked at health-related quality of life specific constructs like social functioning, vitality, and general health perception. I talked a little bit about the construct of pain catastrophizing and fatigue, and there were no differences. The only difference in some of these secondary outcomes was this concept of centrality of pain. It's a construct where patients sort of identify and they have pain in the central part of their being and identity. And there was a difference that did favor the pharmacological arm in this. So our study is limited, in terms of like other VA studies. Do our studies in veterans apply to non-veterans? So we always have to question some of the generalizability. It was conducted at a single medical center. So is our medical center similar to other medical centers? So again, another threat to generalizability. This was squarely framed as a comparative effectiveness, which I think is a real advantage, but the disadvantage is that there was no usual care control arm to see if our interventions were significantly different than usual care. So we concluded that a nurse care management intervention focused on pharmacologic management, optimization, reduce the pain impact and severity more than a behavioral intervention that's guided by CBT. We note that both treatment groups did improve, but the improvement across both groups was very modest. The pharm group the improvement was statistically different, but we really question whether that's that difference between group differences represent clinically significant differences. I think in terms of future directions, we still need to look at, were side effects different? In Dr. Krebs' SPACE trial that looked at pharmacologic treatments, especially opiate treatment, we saw in the opiate treatment arm that side effects were significantly more. We might expect that side effects were more in the pharmacologic arm relative to the behavioral arm. We'd like to look at costs as well. Both, as I mentioned, treatment effects were quite modest. And I think that to improve treatment effects, we're really going to need to find combination therapies, especially for patients like these that were quite complex. They had a lot of medical and psychological comorbidity. They had previously, well experienced in terms of other pain treatments. So we're really going to need to find combination treatments that work. So there's some preemptive responses to potential questions. I don't have the data on opiate dose, baseline, and follow-up. I think it's really critical. I haven't looked at the fidelity to the treatment manual. We have some general idea of adherence to intervention context, that that contexts were generally a little better in the pharmacologic arm. And we'd like to do, an economic evaluation, at least looking at intervention costs. So I think I have about 6-7 minutes of questions before Dr. Lee is up. I'm happy to answer questions by email too. I have to run the clinic. I have a patient at 12:30, so I don't have a lot of time to stick around afterwards, but I have time for about 6 minutes of questions if any questions arise.
So one question I had just listening to this, and maybe I apologize if I missed it, but is just thinking to what extent the algorithm, the PHARM arm was emulating what I might be doing in my practice, like how realistic in terms of clinical care, and the things I didn't see were things like NSAID contraindications. I have so many patients that have either renal or GERD reasons that NSAIDs aren't an option, and to what extent they're I'm just curious to see that algorithm because, you know, to what extent was there anything other than just the medicine in terms of like not just combination, but like, you know, the activity and ice and.
Yeah, good question, Mark. So the question, if you didn't hear, is kind of how does this parallel, I guess, clinical practice and analgesic management using the algorithm? It's certainly, I think it's more intensive. I think what we don't do in clinical practice is sort of monitor treatment responses intensively. We don't monitor side effects and adherence. I think more and more we've tried to take the idea of this rational polypharmacy. We've used rational polypharmacy in management of hypertension and diabetes, understanding that different medications work through different mechanisms. So a similar idea of rational polypharmacy might be effective in chronic pain management. To get the best treatment effects, we might use rational polypharmacy using medications that address pain through different mechanisms, through anti-inflammatory or neuropathic pain that is often. So I think that parallels somewhat. We did have data available on their renal function, and we took into account contraindications based on peptic ulcer disease or renal disease where NSAIDs might be contraindicated. So we certainly did take that into account like you would as a clinician in practice. So hopefully that answers your question.
So Matt, the question I have, because the other trial we had some involvement, which got a lot of attention, was the SPACE trial by Aaron, which essentially showed opiates and non-opiate medications were about equivalent with somewhat side effects in opiates. So with this trial, if the media were to ask you in 30 seconds, what's your message? What is your message? Because this provides a somewhat, it's another story.
Yeah. Yeah, it's a tough question. I don't know what my message, I would go with, I think, according to the study, we showed that a nurse care management model that intensified and optimized medication management was slightly more effective than a behavioral arm based on cognitive behavioral therapy. With the caveats that, there were a couple caveats. Adherence was poor in the cognitive behavioral therapy arm. So I think that might have affected that differences. Those differences were probably not clinically significant. So I need to frame this a little better, but I think I would go with that pharmacologic was slightly better, but with the caveat is that clinically significant, different from CBT. I think both are effective treatments.
And the last point I'd make, because of course we're familiar with the whole movement, is to take away opiates, and obviously we need to prescribe fewer, but also in the context of your study, these were people on opiates and you either augmented it with other analgesic strategies or CBT, because sometimes the message from Aaron's study was take everybody off opiates.
Yeah.
So that's, which you didn't do.
We didn't do, and thank you for bringing that up. And I should mention that we were not explicitly targeting opioid tapering. In fact, we would augment with non-opiates primarily. Those were our major thrust, is trying to augment and optimize non-opiates first. But we did not specifically try and taper them off opiates. In fact, sometimes we actually escalated or did what's called an opioid rotation, where if they were on a long-term opioid, say hydrocodone concept, that they might benefit from rotating to another opioid like oxycodone, kind of reset the pain receptors, that we incorporated that concept, which was a common kind of management concept back then. And so we did a little differently manage the opiates than Aaron's SPACE trial.
And
Shelley?
So, Matt, it's always easy for us to sit here on Monday morning, quarterback everybody's studies, but seeing that your patients had chronic pain for 20 years on average before they started the behavioral intervention,
Yeah.
I probably wouldn't, as a psychologist, I wouldn't have done CBT with them because that has kind of the change model. I would have started with ACT, with acceptance and commitment therapy, which is more focused on, meeting people where they are and living better with the pain that's here that may or may not go away. And so I'm just kind of wondering, did you think about ACT at first, and why did you choose CBT over any of the other behavioral approaches?
Yeah, great question. And I wish we would have talked when we were designing this. But maybe a passing thought, I didn't have much experience in ACT. We had just done a trial that we had done kind of brief CBT, and CBT was the most, evidence-based of the psychotherapies for chronic pain, and there hadn't been a comparative head-to-head. So I didn't give much thought to ACT, just out of my naiveness and inexperience and sort of previous trials that we'd done looking at CBT. I think that's a great point, and why we saw the treatment effects, that they had pain for 22 years, a lot of other pain treatments. They were probably refractory to all these other treatments. At baseline, they had very high pain severity, pain interference, disability. They were refractory to a lot of treatments, including CBT, and it probably put them at a disadvantage, and maybe they would have responded better to ACT. So that's a good question, an empirical question that we need to ask. Thank you.